A very short intro profile of Dr. Victor Bampo.
Dr. Victor Asari Bampo was appointed as the acting chief executive officer for the National Health Insurance Authority in January 2025. Until then, he worked for the United Nations as the UN Joint Program on HIV/AIDS Country Director for Kenya and its representatives to the UN Habitat and the UN Environment Program. Before September 1, 2024, Dr. Victor Bampo was based at the UN AIDS Global Center in Geneva, Switzerland, where he headed the Partnerships for Program Implementation Department and was responsible for his organization's relationship with major funders like the US PEPFAR and the Global Fund to Fight AIDS, Tuberculosis, and Malaria. A former Deputy Minister of Health in Ghana, Dr. Bampo was the incident commander for Ghana's Emergency Operations Center, which prepares for and responds to public health emergencies, including Ebola. In his immediate past role, Dr. Victor Bampo served on the Strategy Committee of the Board of the Global Fund to Fight AIDS, Tuberculosis, and Malaria, and was until recently an alternate board member for the UN AIDS constituency, which is made up of 11 UN co-sponsors. Dr. Victor Bampo worked extensively with the WHO, Gavi, UNICEF, the UNFPA, UNDP, Stop TB, and other partners, and has a good network within the global healthcare architecture, both at the headquarters and at the regional and country level. He is experienced in building partnerships with civil society, government, and bilateral and multilateral partners. Before serving in government and joining UNAIDS, Dr. Victor Bampo served for 10 years in various capacities at the Global Fund in Geneva, including regional manager and senior fund portfolio manager.
And it's our guest tonight on The Point of View. Welcome.
Thank you very much, Bernard.
You were appointed January this year, so
Yes.
you've done 10 months.
Yes.
Are you able to compare this to Deputy Health Minister you were in Mohammed's first term? How different are the two roles?
I think it's a different time as well.
Okay.
So, you know, especially with the U.S. stop work order, which means that countries like ours don't have enough resources. We have to make better use of what we have. So I think I'm at a very important place, and I thank His Excellency the President for giving me that opportunity.
So you are thinking more about money to make healthcare accessible.
Absolutely.
That's the focus.
Absolutely.
But that's what you've been doing your whole life, mostly, right?
Yes, but
or at
you
least for a big part of your life in the Global Fund.
Yes, but you see, at that point, I was working on the donor side, and the donors would bring in hundreds of millions, and you could put in place what I like to call the Rolls-Royce model, you know, of any kind of programs that you wanted. But now, money is not, you know, it's scarce. So you need to think very hard. And if a Toyota Vitz model can do, you use that, because it's about saving lives and getting people to have good health.
But NHIS is more like a spending entity. Or do you generate any money on your own?
So we are a spending entity. We are, when one of the things we're trying to do is to move away from being a claims payment mechanism to a strategic health purchasing provider, which means that we are able to dictate, you know, health outcomes because of the financial muscle that government provides us with. We're able to determine the prices of medicines, the prices of services, and even go onto the global stage and give Ghana some kind of platform to discuss what kind of health outcomes we want, as you saw with the Accra Health Sovereignty Summit that happened on August the 5th. So it's an interesting time, and His Excellency the President, the Minister of Finance, and the Minister of Health have given us the tools to be able to deliver on this mandate.
So just explain a bit more when you say you want to move away from just being a claims payment mechanism to a strategic health provision, something.
Okay, so essentially the health insurance scheme, you know, set up in 2003, Act 650. It was amended in 2012, Act 852, and is to pay claims. But now, what we are looking at is getting universal health coverage for all Ghanaians. And universal health coverage has three pillars, where there's population coverage, and I'm proud to say that we are at 20 million, which is unprecedented, and we'll come back to that. Yeah. And then there is service coverage, making sure that every Ghanaian living everywhere can get a service. And then there's financial protection, which is one of the main pillars, one of the three main pillars of universal health coverage, which means that every Ghanaian living everywhere can access quality health care without financial hardship. And that's very important. So it's not just paying the claims and you know that usual banter about, you know, our claims have not been paid and so on, but making sure that we are the bedrock of the reforms that will lead to better population coverage, better service coverage. And for example, we are part of the thought leadership under the direction of the Minister of Health, designing the free primary health care program. We are also supporting the Ghana Medical Trust Fund to develop the Mahama Cares program, which is looking at non-communicable diseases. Why is this important? It's important because 20 odd years ago, when the National Health Insurance Authority was set up, what was causing problems for Ghanaians mainly were communicable diseases, malaria and so on. Now, because of the epidemiological transition, our lifestyle and so on, non-communicable diseases, or what we call the chronic diseases, are taking up fully 40%, 45% of our all-cause mortality. And so we've had to pivot. Now, Mahama Cares is benefiting from the work that we've done over the 20 years as NHIA. So we are also thought leaders in that area. So when I say becoming a strategic health purchasing provider, that's what I mean, that we are using our influence and our knowledge to affect the way Ghana's healthcare delivery is being set up. Free primary healthcare is also looking at a basic minimum package of health services for all Ghanaians, free of charge, from promotive to preventive to curative. So you go to any CHIPS compound, you go to a health center, you go to a maternity home, and you should be able to get some of these services.
No, this is great. The question I have though is, do you control the sources of money you get? Because I know we do pay an NHIL levy as part of the VAT, which has been decoupled and whatever. And then there's also a tariff. So how does that work? Do you determine how much money you get, or this is purely dependent on the finance minister's largesse?
Well, it's dependent on the importance that the government puts on healthcare. And that's why I'm so proud of His Excellency the President, his Finance Minister, and the Minister of Health. Because I'm sure you remember the Capping Act 947, which came about in 2019, which put a cap on the funds that were coming to the NHIA.
In addition to others, I think Get Fund was also capped. Exactly. A couple more were capped.
There were quite a number.
Yeah.
Now, the president, during his campaign, he promised that he was going to remove that, and he has removed that. So we have an extra 3.5 billion cedis that have come to healthcare. Now, what that means is that we have more funds to do more. Now, what we are trying to do also is to do three things. Number one, to get people in government and across the country to have a mindset shift, which looks at how health is important to the development of the country. So, for example, now you hear the Minister for Finance actually advocating for us, because he knows that health is not a cost center. It's actually an investment driver. So when people are healthy, you can be more productive. The second is the focus shift, focusing on specific areas where we can have the best bang for buck, like Mahama Cares, like free primary. Now, if 40+% of people are being, taken away by non-communicable disease, then it's a good idea for us to try to turn off the tap. And how do we do that? By preventive actions, by promoting healthcare, by doing screening. So, for example, if you have a man with prostate cancer at stage 4, and you catch him later, it's better to do what we call a PSA test to see it at stage 0 or stage 1A or B, so that you can. It's more cost effective to manage that case. So once you have that focus on the right areas, you can also reduce your expenditure, and the general health outcomes are better. And then the third one is the reality shift. And I talked about that earlier, that, when I worked at the Global Fund, and to a certain extent the UN, and the US government through PEPFAR was providing support for HIV and AIDS. And some of the programs are really comprehensive, but they're expensive. And we may not be able to afford it in that fashion. So if you want to go from here to Circle, you can go in a Rolls Royce, you can go in a Toyota Vitz, you can go on a motorbike. It's important that you get there. So we are trying to look at things that fit within our reality,
okay,
so that we can deliver.
Let me understand the 120% tariff increase. So already you have the uncapping of the fund.
Yes.
3.4 billion is coming.
Yes.
This tariff, who charges it, and how isn't 120 too sudden, too high?
So maybe to explain a little bit, and just to say that I need us to dial a couple of steps back.
No problem.
So what we are thinking of is that we've done the work, and we think that it should be a 120%.
You are proposing?
We are proposing
120% increase.
Well, it was, it was done by a group of experts. Now, what the law says, Section 33 and 34 of our law, says that every year we must review the service tariffs and the medicines tariffs. We've already looked at the medicines tariffs. Now, the service tariffs, I think the work was started by my predecessors in 2022. But this was there are two types of review that we have to do. This was a really comprehensive one. So I think they could not finish on time.
Okay.
And it's now that they finished. And they're proposing that we do 120% increase. It's gone beyond the, doing it every year, but it's important. Now it has to go to our board for them to look at it and give a, give their view on it. Number two, it has to go to the Minister of Health to give his accent, and then we would then implement it if all of them think it's okay. Why we are not worried is that we have another challenge.
Okay.
And the challenge of illegal, fees at hospitals, where one of the points, the areas of contention, I have a 3-point vision, and one point is looking at patients having a beautiful experience when they go to hospitals. In many hospitals, that is not happening now because they are asked to pay out of pocket. Now, the health providers tell us that we are not paying realistic tariffs, and that is why that is happening. We think that once we pay those tariffs, then there will be no excuse for the health providers to ask patients to put their money in their pockets to pay.
I see. Let's look at this, the overall health of the NHIS. I think you sent us a couple of slides on the amount of money that comes in. From what I see from what you sent us, consistently there's a lower amount of money you get than what is actually the allocation. It seems as if maybe if X amount is allocated, you always get a lower amount. Is this correct? So what is this?
Okay. So the first slide, because as you rightly said, 2.5% of VAT comes to the National Health Insurance Fund, which is then given to the authority. So there's some, and then there's also some funding from SNIT. So the gray line is actually looking at the projected revenue that will come in. So that's the top line. The blue line is actual transfers. Oh, no, the red line
is actual transfers.
Is actual transfers.
So the red line is always lower than the gray line.
And yes. And the blue line is the budget allocation. So for example, last year, the allocation was 6.5 billion. This year, the allocation was 10.07 billion. For 2026, the allocation is 11.3 billion. Now, if you look at the gap between the first line and the second line from the top, you'll see that from 2019, and I'm sorry, this version doesn't
show a proper version as the program proceeds.
So from 2019, there's some sort of gap between the gray line and the blue line.
Yes.
And how is that explained? It's explained because there's a difference between the projected revenues and what is in the budget. You understand? So for example...
So they always allocate lower than what you are calculating you will get?
No, because of the Act 947. So let's take 2020.
The capping?
Yes. So 2024, the anticipated revenue was 9 billion. But then in the budget, they were given 6.5 billion. And what was actually given to NHIA was 5.9 billion.
Fair enough.
So there's that gap. So that gap. Now you see that for 2025, that has closed. So the gray and the blue have merged.
The gray and the blue should be one line.
Exactly.
So what has happened is that between 2019 and 2025, there's been a gap.
Exactly.
But the red is always below, anyway.
The red is always below because, it depends on how much collections there are and how much is transferred to the NHIA. But what I can tell you from 2025 is that even though the red is below, as at now we are at about, we project to be at about 8 or 8.5 billion out of the 10.07 billion. But I can tell you for a fact that there is no facility that would say that we've not paid them if it's not an operational issue. It's not, I brought some of these to show you. A few years ago, private health facilities were sometimes complaining, withdrawing services because they've not been paid for 9 months and so on. Now we are on a regular, predictable path where every end of the month we pay all facilities. Now, if you go out there, would you find some facilities that have not been paid? Yes. Kolebu, there's some months that they've not been paid. There's a reason. It's not because of finances. It's because some of these facilities are very big. Okay. They have 90 days to bring the claims. And then for facilities like Kolebu, we need maybe a month to do the review.
I see.
So it takes some time.
We will come back to this chart later to look at the proposed financing health reform. But to look at the health of a scheme, beyond the fact that you have enough money, it's about whether the card actually is accepted.
Yes.
There was a story done by the Fourth Estate last month where a number of state-sponsored facilities were actually refusing or turning away people who came with Ghana card, the NHIS cards. UGMC was one, Legon Hospital was another, Trust Hospital was another. Apart from apart from Ridge Hospital, which is the Accra Ridge Hospital, and I think 37, a lot of the facilities they visited, when you said you had a card, they would say go to another hospital. Now their concern is Bank of Ghana Hospital, the hospital in Tema, which are all supported with state funds. Why should they say no to the NHIS card?
So that's an interesting question, and the truth of the matter is that some health facilities have not signed on because you have to get your accreditation, and then you are able to accept the card. I know for a fact that UGMC has not subscribed. They are a quaternary health facility. I think Bank Hospital as well. But we must look at it within a certain context and remember that perhaps these facilities that you've mentioned, there's a little bit of selection bias, I think, because we have 5,000 facilities. And every day, even as I sit here, some of my former classmates who are working in the US and so on, I can give you names, people who've set up here and call me and say, can you help me to get our paperwork right? So if in the larger scheme of things, it is working. Remember, that
no, I'm not saying it's not working. This is more a question of discrimination by the facility. So this is not about whether the card is good.
Yes.
I think the concern for the story was that International Maritime Hospital, UGMC, Trust Hospital, and then BOG Hospital, which are hospitals which are highly resourced.
Yes.
With public funds.
Yes.
Why are you saying that the basic insurance card that's supposed to give healthcare to Ghanaians, they don't want to recognize it?
So I want to flip it around. And Bernard, I'll come to that. What I wanted to say was that let's start with what's working and come to what's not. So remember that the health insurance scheme is the largest social protection scheme or program in Ghana. As we speak now, an unprecedented number of people have subscribed to it. We wanted to reach 20 million at the end of December. Just a few days ago, as you rightly said, my minister announced in Parliament that we are over the 20 million. That's 60% of people. We are using data to guide the way we enhance the products that we have. And we are using it as a basis to get better health. I talked about free primary health care, and I talked about Mahama Cares. So for a large group of Ghanaians, it is working. Secondly, I cannot speak for hospitals like UGMC and Bank Hospital. I do get the point, though, that it would be good if they were using it. But there are alternatives. Because you mentioned all these hospitals, but there are also a raft of hospitals. If it's not working in one place, you can go to another place. Because, and like I said, I'm not speaking for them. Some have made some investments they want to recoup and so on. That's fine. But that's my